This podcast is geared toward primary care providers who see women in the office and discuss breast cancer risk and screening. We will review ways to identify women at elevated risk of developing breast cancer, and then we'll discuss enhanced screening and chemoprophylaxis recommendations for those women at high risk. Reasons to assess risk are clear. In order to provide the best care possible and to make sure that women receive accurate information about enhanced screening, genetic testing, and prevention guidelines, we must know their individual risk. Rachel is a 37-year-old new patient who comes in with a question about breast cancer screening. She has a family history of 2 second-degree relatives with cancer, a grandmother with ovarian cancer, and an aunt with breast cancer at age 54. Assessment of breast cancer risk can occur at either the patient or the clinician's request. Many women will come in and ask about their own risk, sometimes with new breast symptoms or a relative with a new diagnosis of breast cancer. But if they don't, it is important for the clinician to assess risk. Most clinicians will initiate a conversation about breast cancer risk when a woman is 40 or when she establishes care and you recognize that she may have a high-risk family history. Taking a comprehensive family history is the first step in assessing risk for breast cancer. But identifying women with a previous history of a breast biopsy or chest radiation is also important. The 3 models used most often to evaluate breast cancer risk are the Gale model, the BCSC model, and the Tyrer-Cuzick model, which is also called the IBIS model. Each of these models have pros and cons. The Gale model has been around the longest and is the quickest to use, but may underestimate risk in women with a more extensive family history, including second-degree relatives. The BCSC model is the only model that includes breast density, so it can be useful for women who have had a previous mammogram. The IBIS model incorporates second-degree relatives into the prediction algorithms. Women can be classified as high, intermediate, or average risk. Screening recommendations are clear for average risk women, and high-risk women are eligible for enhanced screening and chemoprophylaxis. Less is known about how to manage women in the intermediate risk group. It is important to reassess risk every 5 years, or if there is a new breast cancer risk concern, such as a relative diagnosed with cancer or breast symptoms. The recommendations for when to refer a patient for genetic testing are based on family history and ethnicity. This slide identifies family history traits that can stimulate a referral for genetic testing. Results from genetic testing can include high-risk variants, most well-known being the BRCA1 and 2 gene mutations, moderate risk variants, and then other variants of unknown significance. Women with greater than a 20% lifetime risk of developing breast cancer are eligible for enhanced screening with annual MRI along with mammogram. Rachel's risk is markedly different in these 2 models. As you can see, the Gale model estimates that she is average risk, while the IBIS model places her at high risk. The IBIS model emphasizes second-degree relatives, while the Gale model only accounts for first-degree relatives. Rachel was referred for genetic testing, which was negative. Women who are at elevated risk are eligible for risk-reducing medications, also called chemoprophylaxis. Synthetic estrogen reuptake modulators and aromatase inhibitors are indicated for 5 years in high-risk women. Discussion of initiating these medications should include a shared decision-making conversation covering potential risks and benefits of these medications. This is a chart of the different medications that are FDA approved for chemoprophylaxis. As you can see, tamoxifen is the only medicine approved for premenopausal women. Most of these medicines provide a reasonable benefit in terms of decreased incidence of breast cancer, but also have potential side effects. It is unclear when to start medications, but many women will elect to start the 5 years of therapy about 10 years before the age of diagnosis of their relative. So, if their aunt, for example, was diagnosed with breast cancer at age 55, it makes sense to take chemoprophylaxis for 5 years starting at age 45, as long as she is done with childbearing. A risk-reducing bilateral mastectomy is indicated for women with high-risk gene variants or previous chest radiation and can reduce risk of developing breast cancer by up to 90%. A shared decision-making conversation can help women decide whether to have this procedure. There is no further breast imaging recommended after mastectomy. Coming back to our case, Rachel is deemed high risk based on the IBIS model. She's not a candidate for a risk-reducing mastectomy, but may be a candidate for chemoprophylaxis if she thinks that the benefits outweigh the risks for her. She is also eligible for enhanced screening with annual MRIs in addition to mammograms, starting 10 years before the earliest cancer in her family member, which would be age 44 in her case. Accurate risk assessment will ensure that women receive appropriate counseling and management to prevent breast cancer and make sure it is diagnosed early. Thank you for listening.